Welcome to the Mindfulness Academy Podcast. I'm your host, Amy Morgan, and on today's show, we have Joshua Wellington. Welcome, Joshua.
Hello, welcome.
I'm excited to tell you a little bit about what he does. Is it okay if I call you Josh, or would you rather go with Joshua?
Joshua works great.
Awesome. We'll go with it. Dr. Joshua Wellington is a demonstrated leader in the field of interventional pain management. With over 20 years of experience practicing interventional pain care, Dr. Wellington has developed a reputation for providing compassionate, individualized care to patients. Dr. Wellington received his medical degree from the Medical College of Ohio. He completed a physical medicine and rehabilitation residency at Spaulding Rehabilitation Hospital, associated with Harvard Medical School. He went on to complete a fellowship in pain medicine at Children's Hospital Boston, Beth Israel Deaconess Medical Center, and Brigham Women's Hospital, associated with Harvard Medical School as well. Dr. Wellington holds dual board certification in physical medicine and rehabilitation, as well as pain medicine, and is a member of the American Society of Regional Anesthesia and Pain Medicine and the American Academy of Pain Medicine, as well as the North American Neuromodulation Society. Dr. Wellington brings his vast training in pain management and meditation to his newest position at the American Pain Consortium Center for Pain Management in Carmel, Indiana. Welcome to the show, Joshua.
Thank you, Amy. That was a mouthful to get through. I'm very impressed that you were able to deliver so eloquently from the beginning. So,
well, thank you.
Obviously a great show.
Well, we'll find out. I think this is going to be a great conversation. You have just an impressive background. And I remember we met, it's probably been maybe even 2 years ago, at least a year, probably a year ago.
I think last fall, the weather was nice like it is now, but winter has since gone and come and gone. But it was at a birthday party in the neighborhood where you live, and my daughter had been invited. And as the kids played and the parents milled about, we had the great fortune of starting up a conversation, and look where it's led us today.
It's so wonderful. I kept thinking, what is this guy all about? I kind of got this vibe of like, you're just not, you're just out there a little bit in your own way. You have your own way of doing things, and you had seen a lot of life. There was something I felt like I needed to learn from you, and I did, and have continued that. So thank you for opening up and sharing with me about your background and where everything has led you. I would like to start, and I love to give our guests a little bit of a peek behind the curtain. Would you tell us a little bit about where you grew up and a little bit of kind of your work background? I think we have some of your educational background, but if there are other things you'd like to fill in, please do.
Of course. I'm a Midwesterner. I grew up in Ohio, in a small town, Wapakoneta, which has been known in the past as the home of Neil Armstrong, the first man on the moon. And so a small town, 8,000 or 9,000, everyone pretty much knew everyone. I have a brother and sister who are twins, a year and a half younger than me. Grew up near my grandparents. Small town, again, a lot of farming, little manufacturing. But my dad was a pharmacist, and that kind of interested me in medicine. My sister was the smart one because she went into pharmacy, whereas I somehow got detracted into medicine. And that was a life choice that once I had entered, there was no going back. It's a big commitment, but it has been something that has really given me a remarkable fulfillment in life. After getting through my education and basically sacrificing my 20s to college and medical school and residency and fellowship, and finally, and that was out in Boston, as you mentioned, Amy. I was through the Harvard hospitals, just a remarkable education, a wonderful place to be, but a great place then to springboard from. And I had to come back to my roots because my wife and I were looking to start a family. And my brother happens to live in Fishers. And so in Fishers, Indiana, we thought that would be a great place to be. My parents still live in the same hometown. My sister landed in the Dayton area. She works as a clinical pharmacist. My brother works for Lilly, and I found a job at Indiana University where I remained for 19 years after my fellowship and really focused on advanced pain therapies. When I say advanced pain therapies, I'm speaking about things above just the basic medication management, above like injections. I'm talking about things like spinal cord stimulation and targeted delivery of medicine directly into the spinal fluid with an implanted pain pump. And that can be used for the treatment of chronic pain, for cancer pain, as well as for the treatment of spasticity using baclofen. So I began to develop an expertise in this. It was something that I had seen in my fellowship when I was at the Brigham and Women's Hospital, who has a relationship with the Dana-Farber Cancer Center. And I was having one of those moments in life that impacts your course and your trajectory. I remember rounding with the oncology team as the chief fellow, and there was a farmer who had come in, intractable pain, metastatic cancer everywhere. They were giving him IV opioids, trying to treat his pain as best they could, but he was just absolutely looped out from the opioids trying to treat his pain. We identified this could be a great candidate for spinal drug delivery. And what makes that different than oral or IV, which is systemic, going through the whole body? By targeting the spine, there's actually very little spread outside of the body. And targeting the receptors directly allows an incredibly small dose to be very potent. So a dose in the spine is equivalent to 100 to 300 times what it would take by mouth. And so we can use incredibly small doses to target pain. And with very little systemic uptake, basically, we can treat pain and give somebody their brain back and not have the incredible sedation and other side effects that systemic opioids can cause. So we had identified this gentleman. We took him to the operating room and planted a pain pump. We were able to get him off of those opioids, send him home. And I remember he came back in the clinic a few weeks later, and I asked him, how are you doing? How have things been? And he was like, well, this was an old farmer. He's like, well, I just fixed the roof on my barn and things are going pretty good. And I was like, I'm sold. Sign me up. This is what I want to do for a career. I was just so impacted by the fundamental change in his quality of life that I wanted to really devote myself to that. So in landing at IU, at the medical center, my background is in physical medicine, and I did a pain medicine fellowship through the anesthesia departments at Harvard. But that put me in a unique position that Indiana University, the anesthesia department, actually hired me on, even though I'm not an anesthesiologist. And it really allowed me to focus on pain medicine. And with the passion that I had to try to improve people's quality of life, I met with the hematology oncology department, started to develop relationships, let them know that we really had something to offer to help their patients, and started to get a response. And it was remarkable. And then, patients from neurosurgery who didn't have other surgical options, the gastroenterology department, people with chronic abdominal pain who'd had no other options, were suddenly getting their lives turned around with targeted drug delivery with pain pumps. And it was just remarkable. And it just continued to build and build to the point where in town, private practice, the Center for Pain Management with the American Pain Consortium, recruited me last year to be their medical director for targeted drug delivery with pumps. And it's just been a wonderful continuation of the journey that I've been on. So it's exciting to be positioned in a place where now I'm working with a number of different colleagues in pain medicine across Indiana and Ohio, and we continue to expand. It's a remarkable opportunity for me to take the message of these advanced therapies and try and get them more well known, because spinal cord stimulation, people might have heard of that. Targeted drug delivery or pain pumps, most people have never heard of that. Many physicians are even unfamiliar, and it's has a lot of mythology that when you throw in the opioid epidemic, carries negative stigma. And patients with pain already deal with so many negative stigma that it can be very difficult to negotiate the medical system. And so when you're trying to advocate just for better quality of life and all you're offered are pain pills or injections, it can be really difficult. And it's one of those invisible disabilities, chronic pain. People don't walk around with a number on their forehead that says, I'm 8 out of 10 today. I'm 9 out of 10, but I'm still putting on my best face. People just don't get that. And it's so difficult even for people's family members to understand. So to have methods where we can uh, change fundamentally how pain is processed at the central nervous system gives me the unique opportunity to be um, a catalyst for change in people's lives for the better. And that's why after 20 years, I'm still so excited about it. I love to talk about it because, again, there's so little understanding, even in the medical community, about advanced pain therapies and how many people could have their lives turned around. It's not going to take pain away, but it's about making it manageable. It's about bringing quality back to life, about bringing function back to life so that people can be a part of their life. And that's where it kind of ties in, I think, that mindfulness component that, I mean, to me, mindfulness is about being present in the present moment. And when people are dealing with chronic pain, it's always like that monkey on their back they can't get rid of. It is almost impossible to be present, to sit with someone and just be there in that moment because they're always being dragged down by the pain. So it's been a really remarkable journey for me to be able to um, develop, I think, a remarkable practice for treating chronic pain, cancer pain, spasticity, to try and help people's quality of life and kind of inject my little bits of influence regarding mindfulness and meditation. I will often make recommendations to patients that, our body is connected to our mind and we don't want to forget that. So it's that mindfulness that we all can try to use to empower ourselves to not be defined by something like pain.
Ooh, I love that line. Not to be defined by pain. I think we are defined by a lot of things, but to consider what life means if you are defined by pain. I don't know if you've had this scenario, but I feel like a lot of times when I meet folks who have had something very traumatic happen to them physically, they want to tell you about that very quickly. And it's like they want to be defined by that, but sometimes they also really want to be healed from it. I think
Yeah.
it's maybe a little bit of a call out. There's something that needs to be fixed. I'm wondering if we could demystify this whole pain pump thing, because what I'm hearing is it sounds like a fantastic idea, really, full stop.
Mhm.
What is it? I want to ask a few questions. What does it look like physically? So let's just put some imagery around it and how it kind of functions. And then I'd like to hear a little bit about what you think it might take to make this more mainstream. What do you have to overcome? So let's talk about those couple things.
So, what is a pain pump? Pain pumps have been around, or I should say pumps, because they're used for pain and spasticity. It's the same pump. It's delivering medication to the spinal canal. And that's what makes the magic happen, the effectiveness of that drug delivery, which targets the receptors. So pumps have been around a little over 30 years. We've really learned a lot more in the last 10 to 15 years in terms of how to optimize the therapies to get the best delivery of the medication to give the best outcomes and results. The pumps themselves are fully implanted devices with a small catheter that's about the size of angel hair pasta. So, a very tiny tube that can be inserted into the spinal canal just through a needle. So, this is minimally invasive surgery. It's done as an outpatient, takes usually about an hour or so. So a catheter can be placed through a needle into the spinal canal with the tip advanced under fluoroscopic guidance until it's just at the right place on top of the spinal cord to target the receptors where the pain is the greatest. The catheter can then be tunneled underneath the skin to where the pump can be implanted. The pump is about the size of a hockey puck or a tuna can in terms of its diameter. It's not quite as thick. It's much thinner, or a skull can, you might say, in certain companies in the Midwest. But that's about the size, and it can be implanted under the skin in the abdomen or in the flank of the back, and the buttock. It's just trying to find the best place for each person's body habitus. So the pump is implanted underneath the skin, and it has a little port in the center, similar to people who get IV ports implanted on their chest for like chemotherapy and other IV infusion therapies. So this is basically a pump with a spinal port. And that port allows for refills of the pump, which usually are every 3 to 4 months. The pump has a battery life of about 7 years. It's fully MRI compatible. And these are important considerations when you're dealing with people who have usually multiple medical comorbidities and may need to have MRIs. So it's nice to know that this is a compatible system. It's fully programmable. So we can program the pump for different dosing at different times. It's very flexible to help as a clinician, to customize dosing to each person's needs. Did you have a question,
I
Amy?
did. I was curious if even these folks have, if they have issues going through like airport security and things like that. Is there any kind of metal or things like that?
So the pump is made out of titanium. Sometimes it may be detected, sometimes it may not be. But like other people who have implants, whether that's knee replacements, hip replacements, pacemaker, you get a device identification card. Same thing with a pump. So people would get a device identification card if, in fact, any security equipment would ever trip it off. Now, it doesn't get affected by security equipment or electromagnetic interference. It's also a closed loop system, so it cannot be hacked, which is certainly an important consideration in this day and age. As I was saying, it's fully programmable with a tablet that clinicians have that can communicate to the pump as long as we're within about 10 feet of the person. And that allows us to customize the dosing. Now, prior to even considering implant, we actually are able to do a trial, just a single injection of medication for pain or for spasticity to demonstrate that it works. It also allows us to assess for any potential side effects. And then that can help the clinician to initiate a strategy of how we're going to start the dosing for the pump, whether we want that to be a continuous infusion or maybe a low basal infusion with boluses a couple of times a day. A bolus is just a single dose over a small amount of time. And this again just has a remarkable impact on the patient's quality of life because that dosing again just hits those spinal receptors. And since we're 100 to 300 times more potent than oral, I'm generally initiating this at 100 times less than an oral medicine. I mean, at often less than a milligram a day. In fact, I usually start people off at a 20th of a milligram per day. It's remarkable, of morphine or Dilaudid, tiny, tiny dose. And when that small of a dose is being administered into the spinal fluid, even though there is a little bit of systemic uptake into the blood to process through the liver and kidneys, it is so minimal, it really causes no cognitive deficits. And additionally, it doesn't induce tolerance, which oral medicines, oral opioids can induce tolerance, which means you start taking an opioid and over time, it just it's not as effective. You need higher doses to get the same effect. We also know based on research that long-term exposure of opioids to the brain can cause something called opioid-induced hyperalgesia, where the opioid induces this hypersensitive state in the brain to pain. So your pain thresholds actually start to lower and your pain increases. The opioids start to do the very opposite of what they're intended to do. So for short term, they can be fantastic for surgeries, for accidents. Long-term administration for most people is not going to work. However, the spinal delivery goes around that. We circumvent the problem by avoiding the brain, and the spinal fluid, the delivery in there, it just spreads a few levels of the vertebral spine. It doesn't go all the way up to the brain, or again, minimal exposure so that we don't induce tolerance. We don't induce that hyperalgesia, that hypersensitivity to pain. And so this can be a lifelong therapy for patients.
I feel like it's probably required to ask this is, um, are there certain folks this tends to not work well for? And I don't know if you have that generality, kind of a broad stroke. I'm also curious if you have seen any sort of negative effects, some side effects, what those might be.
Sure. Uh, So again, this is a targeted therapy. So like spinal cord stimulation, if you're going to use that to treat pain in the back and legs after a failed back surgery, this is also a targeted therapy. It's not going to help widespread pain. That's kind of the bottom line for who is this maybe not for? It would be for somebody with widespread pain from fibromyalgia, widespread pain from arthritis, widespread pain maybe following a stroke or a brain injury. It's a targeted therapy. And so, however, I've had some people where if we target the worst of the pain and we make that 50 to 80% better, then the rest of the pain, even though it's there, it's a bit more manageable. So those are considerations too. I mean, again, I think the central sensitization syndromes like fibromyalgia and others, those it just doesn't work for. But when we've got a target like significant neck pain after a fusion, back pain after back surgery, or maybe somebody's not a surgical candidate because multi-level degenerative changes, they can be really good candidates. People with abdominal pain after from chronic pancreatitis or Crohn's disease or ulcerative colitis can be great candidates. People with peripheral neuropathy who have maybe failed a trial of spinal cord stimulation can be good candidates. Pelvic pain from endometriosis or after surgery, again, can be very good candidates. I mean, this can be a therapy that can just so fundamentally change people's lives. I would say it's not generally used for the treatment of migraine or headaches also, but many other pain syndromes it can be quite appropriate for. So then the second part of your question, Amy, remind me what you'd asked.
If there are any side effects, sounds like
Oh,
you have a trial, and
yeah.
if that shot just doesn't go well, what does that sometimes look
What
like?
does that look like? So, opioid side effects, and this is one of the reasons really I do trials because it's not so much is it going to work or not going to work because it almost always works. It's are you going to have significant side effects? And those can include itching, and sometimes that itching can be really bad. Nausea and sometimes vomiting, which can sometimes be really bad, and urinary retention. Those are the three most common side effects. Now, if somebody has itching so much that they actually develop hives, that is not going to be a medication that could be used. But if you did a trial with morphine, you could always consider doing a second trial with hydromorphone or Dilaudid, and that is less histaminergic. It's less likely to cause itching, so maybe that might work. And maybe you do a second trial with Dilaudid and they get itching again, but maybe they don't get hives. Well, you could consider a trial with fentanyl at a very low dose. Fentanyl in a controlled setting can be safe. I know it's in the news a lot. People have had fentanyl poisoning and overdoses. It's horrible. But in a controlled medical setting, it can be life-changing. And again, this is even less histaminergic. When I say histaminergic, that means something that's likely to cause itching. And so we have this algorithm of being able to trial maybe different medications to try and get pain relief. And we even have a non-opioid medication called Prialt or Ziconotide, which is a calcium channel blocker. It's not even an opioid, doesn't cause respiratory depression. That can potentially give pain relief. That, although has a different side effect profile of sometimes difficulty walking or ataxia, as we would say, or nausea, and sometimes confusion or hallucination. So different medications can potentially have different side effects, but they can also potentially offer a window to a better quality of life. And it's just trying to assess for those side effects at the time of trial and then move forward with the best potential medication. Opioids sometimes, and this won't be seen at the time of a trial, but in a small cohort might also cause fluid retention or lower extremity edema. And so again, if that bears itself out, typically we'll try and rotate through different medications to see if we can get resolution of the edema, but still maintain pain control.
Two questions here. What is the longest you have treated one person with the pain pump? I'm kind of curious about the longevity.
Mhm.
And well, let's start there. I'm curious about
Yeah,
that part.
so for the duration of my career, 20 years, and there are some patients who have had pumps for even longer than that. I mean, going back nearly 30 years. Again, the pump is 6 to 7 year battery life. So basically, people come in about every 6 years and we'll just change out the pump. So it's kind of like people who have pacemakers. You just change out the pacemaker when you get to the end of battery service. Same with the spinal cord stimulator, same with a pump. So every 6 or so years, the pump would just get replaced with a brand new pump. Of course, we also assess the catheter to make sure that there's patency and everything's okay with the catheter. But this can be a lifelong therapy. I have many of my patients who are on their third pumps, maybe their fourth pumps. It's remarkable, and almost all of them would say they would never go back. They would never give up their pump because it's made such a fundamental change in their quality of life.
So incredible. I'm curious about another audience, if those with diabetes are good candidates or not, or it depends on the particular person to a certain
So
extent.
they may be a good candidate if their diabetes is controlled, because we know that if diabetes is poorly controlled, and that can be monitored by something called the hemoglobin A1C number. If it's below 8, they can be appropriate candidates just because surgical risks can increase when it's above 8. But let's say someone has diabetic peripheral neuropathy, and their diabetes is in appropriate control, but they're just suffering from the neuropathy. They could be a very good candidate for a few advanced therapies, for potentially something called dorsal root ganglion stimulation, which is another type of neuromodulation, spinal cord stimulation, for which it actually has an FDA indication to treat neuropathy, and targeted drug delivery. So, three advanced therapies could potentially help people who are suffering from neuropathy, whether that's from diabetes or even idiopathic neuropathies, of which there are many out there.
Very, very fascinating. I'm learning so much today. I I wonder, let's transition a little bit into how you utilize mindfulness in your practice and how that kind of sets you apart. I can imagine, um, I mean, my path to mindfulness was kind of just a bit of an emotional pain, even. And I tell you what, sitting with pain, whether it's physical, like you work with, or if it's emotional pain, and can be very challenging. So, how do you overcome that? And what sorts of modalities do you use?
That's an excellent question and segue. I think that, as I said, mindfulness to me is being present in the present moment. It's being fully aware of who you are and who you're with, and in what surroundings you are. And in pain medicine, I think that too carries a stigma of, on the prescriber side, that maybe prescribers are just uh, prescribing a bunch of pills. I mean, I think that led to the opioid epidemic, from which there's been a significant pendulum swing back in the other direction, so that often patients aren't even able to get appropriate medications or therapies. But I think that what sets my practice apart and me as a physician is that when I'm with a patient, I am truly with them. When I walk through that door and I'm in the examination room, I give my full attention to that person, to their story, to really try and honor what their journey was that brought them to me. And because of that, I may often run behind, but it's because I don't want to run by the clock either. I don't want to have my hand on the doorknob at 5 minutes, particularly when I'm evaluating new patients. They're all coming with a story, and often a story of stigma, of heartbreak and heartache, and being misunderstood, and being burned from people and healthcare providers who just didn't give them a chance or didn't listen. And what I've found is being mindful in the sense of just being quiet and being there in the moment and listening with them and just being another human being, to honor their humanity and listen to what brought them to that point in their lives. And then being able to offer them hope that maybe there are treatments that could make things better. And often when I'm meeting people for the first time, I like to really dive deep into their stories, but I also like to say to them, we have to have realistic expectations. If I could take your pain away, I would, and I'd be the most popular doctor in the world. I can't do that. I can't take your pain away. But if I can make it more manageable, if we can work together to find strategies to improve your quality of life, then we've made a difference, because I think of things in terms of a ripple effect. And if I can touch someone's life, that's that pebble that gets thrown out into the pond, and it just starts to expand, because then they can give themselves more fully to their family, to their friends. They can perhaps have the chance to actually be mindful themselves and be more present with those who they love and who love them. And so I try to use mindfulness in that capacity in my practice. It's not like I throw a shingle up outside of my office and say, hey, this is a mindfulness office, but it's how I implement my approach to patients. It's how sometimes I will drop in a suggestion about meditation and the data behind it, for which there is ample data that meditation can be remarkably helpful in dealing with stress and anxiety, and I would certainly extrapolate that to chronic pain. So that's how I often will incorporate mindfulness into my day-to-day practice.
I believe when we spoke one time before, you'd mentioned about some breathing exercises. What sorts of things, what are you seeing is helping? Is that helping? Is encouraging some meditation? What sort of feedback do you have from the field for us?
I think it's trying to find what works for each person. I mean, I try to practice what I preach, and every morning, as consistent as I can be, I try to have a minute of mindful breathing, where I will take very slow, very deep 5 breaths in and out over about a minute. And that's how I try to start every day, actually, as I'm driving into work, because in the car, I'm not having any external interruptions. I can just be present in that moment, aside from being mindful about the traffic around me, and breathe. And I think that's a great way to start every day. And that can often be something that, when people are feeling overwhelmed, I think to just a minute is not a lot of time to commit to yourself. And it's a gift to ourselves to just take a minute and breathe. If you're getting overwhelmed, if you're feeling a spike of pain, to just breathe and not focus on the pain, but focus on the breath. And I think that that's been very helpful to me, just to breathe. And it just sounds so simple, but it can be so challenging sometimes to implement, or to, especially when we're under stress, recognize that and take that minute to just have a good breath. Um, and then I will typically listen to a little morning meditative message. Not necessarily a meditation in and of itself, but maybe a discussion about the impermanence of things in the world, and how that can be joyful, as much as stressful. And then typically after that, I'll do 3 to 6 minute meditation that's guided, in the car, being mindful, following my breathing as I mindfully negotiate the traffic.
Well, a note to our listeners, this is not necessarily something we advocate.
That's right. I would much prefer to just be as we are, sitting in a chair, but I take my moments when I can, and if that's in the car,
I'm just pestering you.
yeah, I will do it. And so I try to be very consistent with that. And remarkably, in this, it makes me laugh. I up until just this week had been on a streak of 184 days of of being mindful every morning and meditating. And it was just, I think, 3 days ago that I had done my breathing. I had listened to the morning message, but then I think that I got to work and I didn't get to the mindful meditation. I missed it. And the next day I thought that I had, but it went from 184 counter boom all the way back to one. And I just, instead of getting upset, I just had to chuckle and say, yeah, this too is impermanent. And that's how life is. And let's just enjoy it, and let's do our best. And so I'm starting over. I'm on day 4 now.
I love it. I just like the realness of that. Thank you
Yeah.
for sharing all of that. I'd love to talk a little bit about how you got to mindfulness. So this is a little bit more serious part of the discussion. How did your journey to mindfulness begin?
So I think it's as with many things, been an evolution over my life. I think that the course of finding what do I truly believe in, what was I brought up with, what do I want to hold on to, what do I want to refute, that has been a journey. And part of that journey led me to read about Buddhism and the aspects of meditation in Buddhism. And the more I read about it, the more I was intrigued, because it's not something that's typically a part of um, Western religion. And so the more I read about Buddhism, the more I was intrigued by meditation, and I tried to seek it out. I tried to start to practice my own version of just taking 108 mindful breaths with my eyes closed and just feeling the breaths. Um, I went to a meditation seminar on a weekend up in Madison, Wisconsin. It was a wonderful road trip, and learned more about meditation and meditation techniques. And I think, as with many things, we come with preconceived notions that, you think that maybe meditation is you have to fold your legs into a lotus position and home, and it's not that, because we can meditate through motion. We can do walking meditation. And I think I came to realize, as I've been active all my life and was a runner for over 20 years, that really when I was running, I was meditating while I was running. Because what would happen is it was a time I always looked forward to. I would get out, and as I was running that meditation through motion, my mind would clear, and I could just be present with myself and with my breathing. And I very often would be running without music to as a distraction. And that meditation through motion and kind of the recognition and realization that we can meditate in many different ways was a real eye opener to me. Um, and that was, I don't know, maybe 7 years ago at this point, that I did that meditation seminar, which I think really helped awaken the possibilities of meditation and the close synthesis, I think, of mindfulness. And so I tried to explore that more and came across, I think it was on Netflix, that Headspace guide for meditation. And it's become a go-to that I recommend to many patients, because I think that it's still present on Netflix. 8 little 20 to 25-minute guided meditations that also talk about the different types of meditation and how it can be implemented into our daily lives, and how, again, we're not perfect, but as we practice anything, whether you're practicing a sport or you're practicing to improve with a craft or an instrument. The same is true with meditation. The same is true with mindfulness. We have to practice it. And the more we practice it, the better we can get. And it's not like we're striving to be the winner of meditation or of mindfulness. We're striving to be better ourselves, and how that can impact us on an individual level, and then the impact that it has on us and the relationships we have with those around us. And so it's been a fun journey to kind of get to know myself better, to take time for myself when I lead such an incredibly busy life with work, and we haven't even dealt into the family side of things, of which I'm happy to talk about a little bit more. But I think taking time for yourself and meditating, being mindful, it only, I think, helps us appreciate life more, and be better as people.
Absolutely. And I would argue it has an impact on a global level. When you talked about that ripple effect,
Yeah.
just taking that moment to breathe before we respond instead of react can have beautiful ripple effects. And so I appreciate you bringing that up. I know that you are also familiar with pain. You alluded to some of your family life as part of just this big picture of all that's you and your life. I know that you've committed your life to managing others' pain. and some of that, some of the heartache that goes along with loss and ache. Would you talk a little bit about the loss of your son, Ezra?
Yeah, I will, Amy. So on the family side of things, I'm the the father of four beautiful children. With my wife Catherine, we've been privileged to bring them into this world, and our first son, born Ezra, um, came to us full term, 8 pounds, pink, but he had some fetal distress. We had no idea anything was going on, but they kept him in the NICU because of that fetal distress. And 4 hours turned into 11 days until finally, neonatologists didn't quite feel a femoral pulse. They did an echo and saw that there was only half of a heart in his chest. He had been born with something called hypoplastic left heart syndrome and also anomalous vasculature, which really I think is what allowed him to grow to be pink and 8 pounds, because otherwise most babies with that are born 4 or 5 pounds and blue. But that 2 days after that, when he was 13 days old, he had his first open heart surgery. And it was the first of a series of 3 planned surgeries to try and recreate a functional circulation with basically a 2-chamber heart, an atrium and a ventricle, through something called Fontan circulation. So he underwent his second surgery that was planned at 6 months old. He nearly died, but he came back to us. And then at 2.5 years old, he had his final surgery, but he had complications, and we were in the hospital for 9 weeks. He had a subsequent surgery, almost died again, but he recovered. And from that point, from when he was 2.5 until he was 15, he did well. We had no hospitalizations, just routine cardiology follow-ups. He was joined by a sibling, Silver, and then Oscar, and finally Lucy. And so 2 boys and 2 girls graced our lives. And when Ezra was 15, he was hitting puberty and getting bigger, and his heart couldn't quite keep up, and he went into heart failure. We were in the children's hospital for a month with that episode until they could tweak his medicine and get him tuned up to the point that he could come home. But we kind of knew that probably at that point we were going to be on a road towards a hopeful heart transplant. And another couple months later, he was back in the hospital in heart failure for another month. And they officially put him on the heart transplant list at that point. But he got tuned up enough that he was able to come home, and he went into outpatient cardiopulmonary rehab. And I can't speak highly enough about the therapists that work with him. They got him so much stronger, and he was doing really, really well. But then as the year progressed and fall became winter, and we got into December, he and I were home one day alone. I wasn't even supposed to be home, and I heard a crash upstairs, and he had had a cardiac arrest. And being a physician, I knew what to do with CPR. You never think you're going to do that on your own child. But I remarkably was able to resuscitate him, and we had EMTs here within minutes. And after 4 days in the hospital, he was able to get his wish and come home and be with the family for Christmas. But right after that, we knew he was going to be going back to be in the hospital, which would put him at the top of the transplant list. And so we were back in January of 2022, hoping that we were going to get a heart. It's one of those hard things because you realize to get a heart, someone else has to lose one. And we grappled with that. And he had a few close matches, and January became February, and he continued to go into more heart failure. And then he just crashed, and he went into multi-organ failure. And we had to let him go because he was suffering. And so on March 1st of 2022, my wife and I held him, and we let him die in our arms. And that was devastating. The loss of a child is like no other loss. It's not the natural order of things. And our kids lost their big brother. And so the pain of that I carry every day. It's changed who I am. I'm generally a pretty happy, positive person, but it's like I have this shadow of melancholy now that will always follow me, always follow our kids, my wife. And so it's not about how do you go on. It's like how do you, I don't know, how do you just keep living each day? It's one day at a time. And we've been fortunate to um, have therapists that have worked with us, that have worked with our kids. And within the Indianapolis area, we're very privileged that there's a nonprofit organization called Brooks Place, which is there for children who have lost siblings and who have lost parents. And we are so lucky that later in the year of 2022, we were able to join a group that meets twice a month. And it's, as we say, kind of the club that nobody wants to be in. But it's a club like no other because the kids get to be with other kids their age and do activities with counselors that kind of come around grief, but don't directly, dive into the incredible searing pain of it. But it lets the kids be with other kids who have experienced that loss. And it lets us parents be with other parents who have lost our children and be with other parents who have lost their spouses. And it's incredibly healing to be able to talk in a group that truly understands. Um, so knowing that pain, there's no other pain like it. And that doesn't mimic physical pain like the patients that I see. And sure, I've had physical pain. I've walked into things and broken my toe several times. I dealt with some stress fractures from running, a pretty awful stress fracture in my hip that had me on crutches for 3 months, and another stress fracture in my tibia that put me on crutches for a month. But those hurts heal. This is one of those invisible hurts that never heals. And it just, I don't know, gives me more sensitivity, I think, dealing with people with pain, whether it's physical or emotional. Pain can be pain. And I think that having that as part of who I am helps me to understand the depths of someone's suffering more than someone else might. So, I mean, I appreciate the opportunity to be able to share that. It's difficult to talk about without crying sometimes, and sometimes I'll cry, and that's okay too. But it's part of who I am, and it's part of how I approach life. It's part of my family now, and we'll always be thankful for the gifts that Ezra brought us for the time that he was with us. And we try to keep those gifts moving forward. And I try to honor him honestly with the mindful practice that I've developed, and often will think of him, or he'll come into my mind. And how could he not? It's just as well as my other kids and those that I'm close to and love. But it's definitely been a major factor that has impacted my life.
Thank you for sharing that.
Yeah.
A lot to carry, and I appreciate you being open with me and our listeners. I hope that that story touches someone. I know it will. So thank you
Yeah, I'm
for
sure.
that.
It was remarkable over the years. I've seen many patients who have lost their children for one reason or another, maybe an accident or an overdose or sickness. And it doesn't matter whether that child is newborn or 16 like Ezra, or 46, or you could have a 96-year-old who loses her 70-year-old son. It hurts, and it changes you um, in ways that you just can't describe.
So well
So,
put. That's so well put. I feel like what would be helpful at this moment as a transitional piece would be if you would be willing to lead us in a mindfulness practice, to give us a moment to breathe and process and sit with the tears that are in the eyes and the throat that's tight.
Yeah, I
I'm
think
noticing that. I'm mindful of those feelings.
yeah, I think we could all use a minute here to just stop and let's just breathe together. You can close your eyes if you want to. You don't have to. You can let your eyes just gently gaze to a far focal point. Or if you're comfortable, let's close our eyes. And let's just take a deep breath in through our nose. Hold that breath. Then blow out through our mouths. And just let the breath be gone. And now let's inhale again through our noses deeply, meaningfully, mindfully. You can let your mind clear, or if something is in it, that's okay too. Holding that breath and now blow out through the mouth. We can't control our thoughts. They'll pass through, but we can just observe them. Let's breathe in again through our noses. Hold that breath. Maybe we've got a thought, maybe it's there, maybe it's not, maybe there's nothing. It's all okay. And let's breathe out through our mouths. And a deep breath again through our nose. Hold it. Breathe out. Deep breath again through our nose. Holding it. Blowing out through our mouth. Let's do one more breath. Deeply in. As we blow out, let's blow out all those cares, those worries that maybe are nagging us today. And you can gently open your eyes when you're ready and hopefully feel a bit more at peace.
Thank you for that. I have a sense that that's similar to what you're doing in the morning, that those deep breaths. Perfect. You led us through your routine. Love it. It
Every day.
is always mind-blowing to me how 1 minute of mindful breathing will just take me from 100 way, way, way down.
Yeah.
It's like a pressure relief valve, release
Wow.
valve. I love it. Yeah. Ooh, okay,
Yes.
we're back to ground zero here.
Finally.
There were many reasons that I invited you onto the Mindfulness Academy podcast. Um, but one of the main reasons was I really wanted to get a little context around the opioid crisis and how you see your work really impacting it. I know we've brushed up against that a few times, but there's a lot that we hear in the news. There's a lot that we hear from friends or family. What sort of context is it growing? Is it shrinking? Give us some context around where this came from and where
Yeah.
it is and where you see it going.
It's it's been something that I think has evolved and changed over the last 20 to 25 years. If we go back about 20 years ago, a little more than, um, opioids were opioids are medications, very powerful pain relievers. They work on receptors in our body that can relieve pain. And in small doses, they can be very effective, but we also know that they carry risks, and the biggest risk is respiratory depression. Um, so if a large amount of an opioid is taken, like morphine or fentanyl or heroin, as an illicit medication, that can cause significant respiratory depression to the point that the person, of course, is going to be so sedated that they will fall asleep, but then in sleep, they will stop breathing. And that's how people die of opioid overdoses. So going back about 25 years ago, um, pain was treated surgically, but the treatment of chronic pain, there wasn't a lot of push for that. We did have the development of spinal cord stimulation, targeted drug delivery with pain pumps had kind of just come out, but the use of oral opioids really kind of got a push with the release of OxyContin. Now, extended release morphine or MS Contin, morphine sulfate continuous, that's how the MS Contin name came out, had been around, and Purdue came up with a formulation using oxycodone that was extended release. And there's a lot of information out there about this, and I won't delve too far into it, but there were addictive qualities to that medication that unfortunately were known. But despite that, the company still really pushed it out there. They pushed it out as a safe medication that could be used for the treatment of chronic pain. And we really need to be assessing pain. And this can be done even at the primary care level. Let's try and treat people who have pain. And so suddenly the market was flooded with prescriptions for OxyContin. And then with its drop of a significant part of the dose into the first 2 hours into the blood, a lot of people got addicted. And this then slowly kind of came to light that this medication was like way more addictive than it was originally described, and that this was kind of leading people into the realm of prescription opioid addiction. And so as this crisis evolved and some practitioners who were more unscrupulous found that opioid prescriptions could be very lucrative, there became almost a pipeline that extended from Appalachia down through Florida, this opioid belt of prescribers, and they would become known as pill mills. And people who were seeking medicines would know where to go. And there would literally be lines outside of these clinics, and it was cash only. And you get your prescription, you go to the pharmacy to get your pills. And it really fueled the fire for this opioid crisis. Uh, as this was being recognized, the pendulum slowly started to swing back. Now, we had advanced therapies, spinal cord stimulation, targeted drug delivery, but these therapies were really only available to patients who saw specialists like myself. And so for primary care physicians who weren't aware of these therapies, really their only two tools were their prescription pads. And they were trying, to help people, but in so doing, a whole generation started to get addicted to pain medications, and very often not seeking them out, had no intention of trying to get addicted to medicines. And as prescription patterns started to get scaled back, as the CDC released guidelines in 2016 recommending that patients or prescribers not prescribe more than 90 milligrams of morphine or its equivalent. And that kind of became a guideline, but then many states kind of tried to adopt it. And it just provided a lot of confusion. And then also, patients who had legitimate pain issues were suddenly not being prescribed the medications that they used to be. And so the only way they could turn was to street opioids, which would be heroin, and then fentanyl, which started to be made. And this is a or a compound that can be made in a chemistry lab, not with your basic chemistry set, but cartels can figure this out. And it was figured out in Mexico and in China, and a lot of fentanyl products started coming in along with heroin. But heroin is something that's twice as potent as morphine. So for people who get addicted and were using this, they could kind of count on what they were doing. But then when fentanyl would get laced in, fentanyl is 100 times more potent than morphine. And so just a few grains of fentanyl laced into heroin would cause someone who would think they know what they were getting to suddenly be overdosed and die. And so the more fentanyl has penetrated into the market of heroin, and unfortunately, these things are so readily available and able to be made that they've become very cheap. And that's why, as the pendulum has swung so far back, that now prescriptions are being remarkably limited, that people who have addictions are their only option is to turn to these street drugs, and then they don't know what they're getting and they overdose. And so we've lost at this point in the opioid crisis More thousands, tens of thousands of lives. Actually, more people have died with opioid overdoses than all of the people who died during the Vietnam War. It has been astounding. And it's a silent epidemic because we're looking at a stigmatized population, addicts. And so if they die, people often say, well, they deserved it, they had it coming to them. Well, that's not kind of how the brain is wired. People don't want to die. People don't want to get addicted to something. It has a lot to do with our genetics. And when that switch flips to addiction, just like with alcoholism, just like with tobacco addiction, it's not like people want to keep smoking. They often think this is dirty. I smell. I don't like it. I want to save the money, but I can't quit because nicotine is such a powerfully addictive medication. The same can be true of opioids. But there's different stigmas with tobacco versus heroin. There's different stigmas with people who are addicted to shopping or gambling. These things light up parts of our brain. Sugar, it lights up the same part of your brain as cocaine.
I had
So,
heard that. So that is actually true.
yeah,
Oh
yeah.
my
And
gosh.
so it's trying to recognize that this is not a population of people who want to die, who are looking to get high. Their switch has been flipped for addiction. They need help. And they're not getting it. Unfortunately, our system in the United States is an unfortunate disservice to people with addictions. And we need so much more resources to be able to help people in a multifactorial way, not just with medication assisted treatment like methadone and Suboxone clinics, but the psychological counseling, the support. There, so much needs to be in place that we just don't have, that people are dying because of it. And so that's kind of a little treatise on how the opioid epidemic developed and then evolved to what we see now, where prescriptions are in such limited basis. And in fact, even the manufacturing has been cut back so that patients who are legitimately prescribed opioids are now having difficulty finding those medications at the pharmacies because the distributors don't even have them because the manufacturers haven't made them. So it's routine that we get calls to our clinic every day that a patient's medications were not at the pharmacy. And then we have to call around to find a pharmacy that might have them and then send the electronic prescription to that pharmacy. So it is incredibly challenging for people legitimately who are suffering with chronic pain just to try and get the medications that are being prescribed legally. It's and so you layer that on top of everything else, and it's no wonder that this is an incredibly complicated and stigmatized situation.
All right. I'm going to paint a scenario or paint a picture here, and I'm wondering how it might work out. Let's say someone comes to you, they are addicted. You have a patient who says, I'm addicted to X, whatever the medication is. Are you able to help them? Is taking care of the pain able to take care of the addiction? Or how do you help that person navigate back to solid ground where the pain's being taken care of, but the addiction can be resolved? Is that a thing? Help me understand that.
So there are clinical specialists, physicians who actually specialize in addiction medicine. Just like I'm a pain specialist, there are addictions specialists. If someone truly has an addiction to an opioid, um, and they have a coexisting pain issue, that's going to be incredibly difficult to treat because ultimately they're probably going to need to get on a medication assisted treatment plan like methadone or buprenorphine, which is Suboxone, concomitant with an advanced therapy because they're not going to be reliable to take oral medicines. They can't. That switch has been flipped. It's impossible for them. So we have to look at alternative means, things that like spinal cord stimulation, like targeted drug delivery. Because again, with targeted drug delivery, we're delivering it to the spine. It doesn't go to the brain. People don't get high. It doesn't trigger that. So working with an addiction specialist, that would be the path forward for a patient in that circumstance. But it can be so challenging.
So they could work with an addictions specialist. And then once they get that under control, you
Yeah,
can come in, your team could come in and help with the underlying pain. Is that how
that's
that
the
typically
goal.
would go?
That's the goal. I
Okay.
mean, and I've certainly attempted that with some patients, that the challenge is that just addiction can be so powerful, and recidivism or sliding back down that slope is unfortunately all too common. And if that happens, then continuing any pain treatment options may be limited.
Sure. Well, I
Yeah.
appreciate understanding the context. Incredibly enlightening. Thank you for that.
Yeah.
Um, do you feel like there's hope for the future? Do you think it's going to slide back another way? I mean, if you look at a crystal ball, what's your gut say?
That's funny because I often tell people I don't have a crystal ball. But what my gut tells me is that I'm an optimist and I have hope and I like to give people hope. And when we have remarkable advanced therapies already available, I think that there's hope for people. But it's also about expectation setting. You know, we live in a world where our expectations really dictate a lot of our worldview. And especially in this country, our expectations are very high. For example, in India, a patient might have a multi-level lumbar fusion and be sent home with Tylenol. That's it. Okay. That is not the expectation in our country. And so we have to manage expectations. And that's why I tell people the day I meet them, usually, I'm not going to make you pain free. We want to try and make it manageable. I want to improve your quality of life, and I will do everything in my power to do so. But we have to have realistic expectations. We have to realize that there's going to be a point where we may not be able to do much more. But you have to be willing to accept that we're working towards a new normal. And that normal is not going to be what you were when you were 20 years old. It's trying to find the meaning in life. And that's why I think where the mindfulness plays in with the lot in life that we've been dealt, whether that's, you know, a surgery that went wrong, a disease process that's progressing, or cancer, whatever it may be, and trying to do the best that we can with the tools that we have to manage things as well as we can.
I want to give you a few moments here to tell us about how folks can get in touch with you, how that even works, where they could find you online, and then we'll conclude with the glowy daily reflection practice. So, what happens when folks have pain? Are they supposed to ask their doctor to come see somebody like you, or would the doctor know to refer them? How does this work?
So it can come a number of pathways. In the Indianapolis area, and I see people honestly across the entire state, as well as Illinois, Kentucky, Michigan, Ohio. I've had patients come as far as Arizona to see me for pain management and for pump management. But it basically boils down to you can get a referral, but you don't need one. I'm part of the American Pain Consortium at the Center for Pain Management. I practice out of a clinic in Carmel, Indiana, and the American Pain Consortium has a direct link for patients who would like to be scheduled. I recognize that I'm a bit popular, and so it might be a few weeks to get in to see me. But as I said, I am very mindful with each person for the first time that I see them to give them the time that they need and not walk out. A physician can refer a patient. The American Pain Consortium has our fax number as well as links to obtain new patient information. So that would probably be the direction that I would send people. We actually also have a podcast called the Pain Pod through the American Pain Consortium. I've been privileged to do a couple of episodes, actually. One of them with a patient who I implanted a pain pump for, and so the Pain Pod can also be available on YouTube or Spotify, along with your wonderful podcast, Amy.
Wonderful. It's really good. You really should check it out. Some amazing interviews on there. And if folks want to go to your website just to kind of get the feel, tell us what that website is.
AmericanPainConsortium.com. And
Perfect.
that is the gateway for getting in to have an evaluation with me or many of my wonderful colleagues. I'm part of a group of private practice physicians, specifically in pain medicine. We are interventional pain specialists. So we are looking to try and help people's quality of life through interventions. We do medication management as well. We do injections. We do advanced therapies. We really want to try and find what is the best option for treatment for each person. So
An
American Pain
individual plan.
Consortium.
I love that.
Yes.
Excellent. Let's conclude our time together with the glowy daily reflection practice. This is a daily practice of mine that I developed and is included in The Chaos Antidote, A Fable About Mindfulness, my first book, and the companion workbook. Um, It is an acronym, and it starts with a G, which means it stands for what you're grateful for. The L is for lift up the things that you might need resources for or someone else might need resources for. The O is for observe, very popular with the mindfulness crew, what we're noticing, very important. The W is for wholesome intention. That could be for today, that could be for your life. And the last one is why for you are. So you get to give yourself a little pat on the back and say, Joshua, you are, and you get to fill in the blank with something to send you off into your day, a little self-love. So we'll start with the G. What's something you're grateful for, Joshua?
I'm grateful just for the air I'm breathing right now. I'm grateful for this moment with you, Amy, to have what will hopefully give a lasting impact for people. I'm hopeful to inspire people who might listen to your podcast, whether they're local or from afar, and perhaps advocate for themselves or a family member or a loved one to find the treatment that they so deserve.
What do you lift up?
Hmm. I think I lift up and honor the experiences of those that I'm privileged to work with. It's, as I said, so often stigmatized when I see people who have suffered with pain. And I feel that it is a privilege when people share their stories with me. And I would lift that up to the universe to say thank you that this person was brought to me and we have the opportunity to work together now. So yeah, just lifting up their experiences of the people that I'm privileged to work with.
What's something you observe inside or outside of yourself?
I think I would observe that life goes on no matter what we're dealt with. Life, I observe the daily getting up of my children, helping them out the door with my wife to school. I like to, and this is where mindfulness plays in, to just take those few moments in the day when you're driving and you see a cloud that's beautiful, or you see that the wind is blowing through trees, leaves in a certain way, and just observe that and be present with that, and um, and take that with you, and just observe, I guess, appreciate that moment in the observation, and something that other people might just not even think about, but that's those moments of observation I think we can cherish, and that only adds to our lives and the richness that we have.
That's the only moment we have, is this one. So
Yes.
showing up for it is
Yeah.
really important. That's what keeps me going. What is your wholesome intention?
My wholesome intention is to leave this world a better place than I found it and came into it. I've always wanted to help people. I think that's what led me to medicine. And it truly is my whole intention to try and help relieve suffering, to help improve people's quality of life, to help raise my beautiful children into beautiful adults, and make the world a better place.
Excellent. Now's your chance to give yourself a little self-love. Acknowledge some awesomeness within yourself. Joshua, you are
A great dad, a great physician, great husband, a great friend, and someone that people can count on.
excellent. Love that. Well, Dr. Wellington, this has been quite a pleasure. Thank you so much for taking the time to share your story, um, and to share with us ways that folks who are in pain can find ways to manage it. I think that is a true gift that you've been given, and I thank you for sharing it.
Thank you for giving me the opportunity. I really appreciate it.
You're so welcome. Well, from my heart to yours, may you live with ease. This is your host, Amy Morgan, signing off. Today's episode is brought to you by Good Aim Communications. To learn more about this full service marketing agency, visit goodaimcommunications.com.